We're back. Strength and Knowledge is back. I'm John Allan, and in this episode, Dr. Olivia Abdoo and I dive into her presentation on the risks of lower body injuries following concussions. Specifically, we discuss the physiological healing timelines and cognitive changes following concussions, why the Buffalo treadmill test does not effectively test true readiness for return to sport, and why some structures are more susceptible to injury following concussions. Without further ado, let's get into it. Dr. Olivia Abdoo, aka Dr. Done It All. You've done residencies, fellowship, worked at the highest level of professional sports, and now you teach courses on concussion rehab, as well as ensure our military is in the best shape to protect our country. You're presenting on the risk of lower extremity injuries following concussions here in a little over a week. Before we get into this data, I'd love to hear how you got here, as well as the any clinical moments or personal experiences that pulled you into this area.
Yeah, John, thanks for having me. Appreciate it. Some kind words there. I don't know about all that, but yeah, as you said, I'm a physical therapist. I'm currently located in Las Vegas, Nevada, working at Nellis Air Force Base, where I'm an embedded physical therapy. I'm a civilian contractor, but I'm in the physical squadrons working with our fighter pilots here. I have a big interdisciplinary team, athletic trainers, strength and conditioning coaches, cognitive performance specialists, massage therapists. We have a lot of surgeons, physicians that we work with. So it's been a great team here to help support our fighter pilots. But yeah, as you stated, I started off back. My big passion is concussion, obviously, and that started way back, actually in PT school. And actually, one of my first in services that I gave was on this specific topic. So I have been refining and continuing to learn over the past over 5 years on this specific topic. So it's exciting to continue to delve into it and see how it's grown and changed throughout the years. But I went to sports residency at Duke University, which was amazing, one of the greatest experiences. Worked and covered a lot of high school, which was amazing. Got a lot of athletic training, acute injury type experience. Moved over to Wake Forest Division One fellowship, just kind of that next level of sports physical therapy and working at that interdisciplinary high level environment. And then after that, came back over to the West Coast and worked for UFC Ultimate Fighting Championship for about 2.5 years. And so they're working with obviously professional MMA athletes, where we did, it's interesting because we initially were not seeing a lot of concussion. Most of our athletes were not coming in for that. And you're like, well, they must not get any concussions. A lot of my time there was building trust with the athletes, educating them, kind of helping them prioritize like why they should care about something like this. And so there I was able to develop their entire concussion protocol, including evaluation, assessment, treatment protocols, and developing an MMA specific return to sport test, working closely with the entire team on that. And yep, so now trying to bring that over to a different type of fighter here with the US Air Force. So that's kind of the spiel there. But I think this topic in particular I find so important and unique because most PTs I feel like don't feel like they treat concussion or know how to treat concussion. But in reality, with all of the research that's coming out, that there is clearly some pattern going on where we have an increased risk of lower extremity injury after concussion, and we're also seeing that vice versa. And so I also find it really important to get a good understanding of this because I really do relate concussion to orthopedic injury. We should be asking all of our orthopedic based patients, athletes, if they've had a concussion in the past and vice versa, because it is a big gap in our care. And there's, tons and tons of ACL literature out there. And a lot of what I bring to kind of my education and teaching and not only getting athletes on board, but clinicians on board is it's all the same. You take all that type of assessment and return to play progression, and we just apply it to concussion as well. It's not this kind of big, scary, very specialist niche thing that you have to do. As clinicians, we should be able to address and treat concussion, and we sometimes are the first line of defense for that.
Yeah, absolutely. I think we'll dive into the research now a little bit. Like, 'cause I think the numbers are pretty significant and a lot more significant than people realize. Like, I think I was reading an article that said like at least two times more likely to get the lower extremity. Is that still accurate today? Is that from the research that you're presenting on?
Yeah, so there's been a lot of systematic reviews and meta-analyses that have come out that showing that individuals who are concussed showed even like a 58% greater risk of sustaining a lower extremity injury. And we're kind of seeing that across the lower extremity, particularly knee and ankle, particularly ligamentous injuries. And that number is relatively consistent across the gambit, where that risk rate is two times higher in athletes who've had a history of concussion. There's actually an article that recently came out that looked at the military population, and they found that concussed individuals were two times more likely to sustain an upper extremity injury. This was primarily muscle strains, but kind of ranges across the shoulder, elbow, wrist, and hand, which is kind of interesting to think about. But a lot of this epidemiological data, we always got to be careful, right? Correlation doesn't always equal causation. There's always, hard to generalize always, some, endless confounding variables, just like with any of the research. But I think with the plethora of data that's out there, particularly from systematic and meta-analyses, which we know is kind of like our top tier research articles, we're seeing this consistently across the gambit and really across sports as well. Not even just contact sports, we're seeing it in volleyball, tennis, and other sports as well.
Awesome. Yeah, there's definitely been a shift, obviously, as we think of concussion rehab, moving away from the dark room and rest and like really, like you said, treating it more like the ACL. How often and how early are you focusing on like the heart rate, getting up the heart rate higher in sessions? And does it vary based on intensity at day one, intensity at like the 1 week follow-up? How are you kind of incorporating like aerobic training in your rehab processes?
Yeah, so I think there's kind of like two different kind of questions and directions we can go with that. I'll tackle the cardiovascular piece first, and then we can kind of dive more into really what are the risk factors that are coming along that are resulting in like why are people getting like extremity injuries? Why do we think that? What is that causation? But for your specific question about cardiovascular, I mean, we're hitting that early. My big thing is that I am not necessarily, to your point, right? We're not putting people in a dark room. But I'm getting people back as quickly as possible to sport specific things as soon as possible. And so that could be day one, especially if they feel good. But from the aerobic standpoint, we do know that steady state aerobic activity is really helpful for speeding up recovery. And that comes from a lot of Letty's work, right? The Buffalo treadmill test, where we do the test, we take 80% of symptomatic max heart rate, and that's how we progress. The problem there is that for concussion treatment, almost always in every scenario, we are trying to push into symptoms. That's the only way we know that they're going to progress. It's literally just like muscle loading, right? Like we have to overload to get progression. That's the only way the body knows how to adapt their physiological demands and tolerance to that load. So I don't use the Buffalo treadmill test anymore. And part of that is the definition of exercise related or concussion related exercise intolerance is the inability to exercise at or near age appropriate max heart rate, right? Because they get symptomatic. So the recommendation is you do the Buffalo, you do sub symptom causing like intensity. You're supposed to repeat the Buffalo every 2 to 3 weeks, which in most cases is really not reasonable to do. That timeline like doesn't really make sense. And that's across patient populations, depending on who you're dealing with, but particularly for athletes, like we don't really have that time, and especially if you're only seeing a patient once a week, maybe in the clinic, we're gonna take half that time to do the Buffalo every time. Not really sure if that's a great use of time. And then the recovery is the ability to maintain greater than or equal to 80% of age predicted max heart rate for at least 20 minutes, several days in a row without symptoms. Now, I don't really know any sport that has that type of energy systems profile. And if you have professional athletes, particularly endurance athletes, they never hit even close to 80% of their max heart rate when they're doing the buffalo. So it ultimately doesn't really make any sense there. And in reality, interval training is what is taxing the autonomic system the most. The reason that we do aerobic cardiovascular training is to assess the autonomic system. The cardiovascular response to exercise is our proxy for the autonomic system, which we know is one of our clinical domains that can be dysfunctional following concussion. And so, really, interval training, high intensity interval training, where you're undulating between really high intensity work and low intensity work, challenges the autonomic system better and helps it adapt much better. So, initially, when I'm programming something for an athlete, I will start with steady state because that is what initially they're going to tolerate. And it tends to actually make their symptoms feel better. So I'm using that as a tool to get them out of really flared up states. But initially, like I'm trying to get them to do 20 minutes of steady state, um, maybe a zone two, right? If they're hitting a zone two, but depending on who you're working with, sometimes it's hard to get to a zone two. It can be a little challenging. So usually I'm just looking for them to be at least symptom free for 20 to 30 minutes, steady state, whether that's on a bike or treadmill. If they are somebody dealing with a lot of vestibular or cervical issues, I might steer towards a bike initially, but transit unless they are a cyclist and they are on a bike, I'll transition to the treadmill pretty quickly, and then I'll quickly progress into intervals, whether it's 30 seconds on, 90 seconds off, progressing to like a true Tabata, right? 40 seconds on, 20 seconds off. I'm building that out. Whether it's usually, right, you're usually doing like longer rest periods in between those higher intensity. It's just like how you would progress anybody back into like your conditioning. But what I think we kind of can lose track of is that conditioning in itself, right? Depending if athletes are out for a really long time, they might have lost all of their fitness. And if they're just jumping back into sport, that in itself might be the reason why they're getting injured because they're not at the performance level that they need to be because they've been out so long. Not as much of a concern if we're getting somebody right off the bat and we're progressing them really quickly. But especially in more of that clinic-based setting, if you're not in that team sport environment, you might be getting people walking in who've had symptoms for months to years, right? Um, so did that answer that question with regards to cardiovascular stuff?
Yeah, you brought up a lot of great points. And do you want to continue on the topic of like kind of how it transitions into the more lower body risks? And then I'll come
Yeah,
back and ask some questions that I had follow up about the first point.
perfect. Yeah. So I think, the big thing with, why I believe that these things are happening, why athletes are getting injured after concussion is goes back to this like recovery timeline, right? We have this like 7-day return to sport or your Wemby and you have a 5-day return to sport, right? Um, and it's like, where did this 7-day protocol actually come from? Part of the problem with that is that there's been a lot of evidence coming out that true neurologic recovery isn't actually happening within that time frame. We're still seeing an energy crisis that can last up to 30 days, axonal dysfunction under diffuse tensor imaging up to a month after, signal dysregulation under functional MRI. We're seeing differences in individuals who are concussed that can last up to 23 months. And chronic inflammation under PET scan could last possibly years. There was an interesting study that was published that looked at 146 university level athletes. So they had 24 athletes who got concussed, and that was a mix of volleyball, hockey, soccer, football, basketball, right? Like um, contact and non-contact. And so they all got brain scans and then they had their healthy controls that they compared to. And they looked at these brain scans after initial injury, once they were medically cleared, and 1 year after return to play. And even after that, at return to play and 1 year after, we're still seeing differences in these brain scans. And so to me, that's telling me that there's something lingering, right? It's hard to know, like, again, that causation correlation, right? There's so many confounding factors, but there's a lot of these studies that are coming out that there are these lingering neurophysiological and neuroanatomical changes. And so that is resulting in some type of change in our neuromuscular function and our output and our ability to perform on the field. We know that there are changes in reaction time after concussion, changes in attentional control after concussion. When we look at actual like biomechanics, we see changes in gait, a slower, less adaptable gait, very conservative gait. It's almost like you're walking on ice. That's like that's how I relate it to. And we're seeing those differences up to a year after a concussion. When we look at more like functional tasks, like landing from a cut or new maneuver, we're seeing increase in E valgus and internal rotation, right? Like sounds a little like ACL type things, right? Whether that's indicative of an ACL tear, I don't know, but we're seeing changes in these mechanics. We're seeing decreased knee extension moments and or increased knee extension moments, decreased knee flexion displacement. So we know that something is going on here. And there's a couple different theories and that have been proposed. I kind of lean into this integrated systems framework, which really is kind of the umbrella for all these different types of theories, where ultimately we know that there's those neuroanatomical, neurophysiological changes that are are altering motor function, decreased muscle activation and force output, change in movement patterns, impaired ability to multitask, um, definitely the attentional awareness, being able to ignore non-important information and focus on good information, switching between tasks, everything we know we need to do on the field, on the court as an athlete. And so these are the long-term deficits that we are not addressing as PTs post-concussion. And I've been chatting with a lot of colleagues, especially about this Wimby who's come back really fast, right? What we don't, who am I to say anything, right? It's like, well, we have a lot of great professionals that are making these decisions. And I think one of the things that I always bring up here is, right, we know that there's lingering issues. What we don't know is, does it matter if they return that fast or if they wait 2 weeks? Because the window of vulnerability probably is a little closer to 10 to 14 days. So I think like definitely for my younger athletes, I very much encourage like we're at least not trying to do contact or risk the exposure of getting another concussion within that 10 to 14 day mark, but I'm getting them out on the field as soon as possible. So that's different than exposing them to contact. I might return them to a lot of practice, but I'm really just trying to avoid them getting a secondary concussion. Because in reality, we don't really know. We don't really know if those like long-term neurophysiological changes, the chronic inflammation, does it make a difference if they go back fast or not? You would assume maybe, but we don't really have that data. And obviously there's a lot of things that go into it, right? Does the athlete understand taking on those risks? If they pass all their tech, right? Just like with ACL testing, they can pass all their tests, but that doesn't actually tell me that they're ready to go. If they fail it, I definitely know they're not ready to go. And it's the same principles that I use for concussion.
Yeah, you again hit a lot on a lot of points. I think one thing I want to come back to is talking about like that vestibular as well as the cardiovascular and like just changes. I feel like the most difficult concussion case for me to treat is the one that like they have no issue with exertional tasks. You can do the buffalo, you can do any exertional task, interval training that you want to do with them, and they feel great. They feel better. They're like, oh my gosh, like this is nothing. And then you have them do head turns, walking with head turns, and they're like that gait instability you were talking about. Like, how does that kind of change your thought process on day one? Are you thinking more vestibular issues when they present like that? And just kind of talk us through about like the thought process on that eval day.
Yeah, so I think your initial evaluation, it's like evaluating a low back, right? Like you have these buckets that we know clinically if you are able to fit somebody into those certain buckets and can tailor your treatment to that decision-making tree, they're going to have better outcomes. So it's the same thing with my concussion evaluation. It's really thorough and can be quite long, but I'm trying to tease out every domain. Because we don't need to treat all the different domains if they're not falling into that. And so the main domains that I practice by are vestibular ocular, we have autonomic, we have the cervical spine. Um, some people don't necessarily put the cervical spine as a domain. It's almost like a modifier, but I have found that if you do not treat the cervical spine, you really can't treat much else either if we're missing that. We have cognitive motor, we have migraine, and we have affective, which is like that anxiety and mood portion. And so my evaluation, I'm going through each of those domains to tease those things out. So if exertional is fine, right? You get them on a bike, on a treadmill, and they're fine, great. We can run with that. I can give them lots of things to do there. That just might be like home program to keep them doing things as much as possible. But if they're truly following into the vestibular domain, I do my full vestibular assessment. And really, we know that that is habituation. And there were I like three really great studies that recently just came out, published in 2025, that showed that simple vestibular ocular motor exercises that can be done at home are excellent, sufficient. We don't need to go crazy and do all sorts of things. That is a really great, easy home program that athletes, patients, kids can do on their own, and it's very, very effective. So I just take my VOMS, my vestibular ocular motor screen, and I give that as homework. Um, and so until but the vestibular ocular motor screen isn't going to be very accurate if they have a jacked up cervical spine, right? We know that the cervical spine, the ocular system, the vestibular system are so closely intertwined, right? They're not going to be able to do their VOR if their neck is presenting like whiplash, which, on that note, we actually can't really differentiate between whiplash and concussion. We treat them the same, but you have to get the cervical spine in order to really get after the vestibular system as well as effectively. And for our autonomic system, we just talked about cardiovascular, our sympathetic ganglion run right under our SCM. And so if you're dealing with somebody who has dysautonomic type symptoms and they're having exertional issues, right? I'm always treating the cervical spine as well. So it is kind of all correlated, but I am making sure I'm checking my boxes. Because then on top of that, if they fit into the anxiety and mood domain, if we're really not tackling that, the rest of it doesn't really matter either. Usually it becomes pretty obvious if they're fitting in that domain because the rest of your evaluation doesn't really line up or make sense. Um, so yeah, I mean, we could go in like a million different directions, so hopefully I answered your question.
Yeah, you made that very simple. I think you're doing a great job of taking a topic that seems like it's very confusing, very diverse, and lots of aspects to it, but you're simplifying, right? You're talking about making it just like the musculoskeletal system. Like we have to progressive overload. We have to hit our mechanical things, like you said, the ganglion coming right on the SCM. Like that's a manual technique. We can calm down the SCM. That can have lasting effects for more than just like a muscular release. I think it makes a lot of sense in regarding like it doesn't have to be a complicated rehab. Yes, it needs to be thought out, very intentional with like how long you're treating people, but also there are things that every clinician was taught in PT school that they just need to apply into the same population. So I appreciate you taking the time to really hammer home those points. Another thing that really like was running through my mind is like the opposite of like all the like the neurocognitive piece of the ACL and causing the concussion. I was going to ask you about have you found any research specifically with ACLs? Because we know, obviously, like I said, the changes in the brain after ACLs and any research that you're aware of regarding the increased risk in concussions there.
Yeah, McPherson has published a couple of specific papers that have looked at significantly higher rates of ACL cases post-concussion compared to match controls. So we are seeing that. And like I kind of said before, a lot of the knee and ankle injuries that we're seeing are actually much more ligamentous. Um, and so you wonder like why you think like proprioception, who what are we missing there? But there's a big, and everybody loves ACL stuff, right? So I think the moment you throw that out, you really grab people. I always point people back to Meredith Chaput and Dustin Grooms with all of their neurocognitive literature that they have published. And again, like it's a lot of it is ACL based. I implement that with my concussion athletes in the exact same way, doing their hop testing in the similar way, adding that neurocognitive task. I think that as PTs, especially when it comes to the neurocognitive piece, we can kind of get lost in the sauce there. And there's a lot of great technology out there and a lot of different things where we can really overcomplicate stuff. But to your point, it really comes down to the foundational, simple things. Um, and so one of the tasks that I really love to use that's super simple is the Simon task, where we have congruent and non-congruent stimulus. So it's super simple. I use Sport React, which is it's a different type of light device and reactive device. Blaze pods, right? It's colors, you tap them out. Sports React, you don't have to physically touch them, and then it comes with a endless supply of stimulus, so squares, letters, arrows, and because you don't have to touch it, you can use it for time gates. You can use a PowerPoint too. Like so simple. But I will have people react. So usually if I'm just doing hands, it's like the blue light, whichever one it is, you have two lights or you have two squares on the PowerPoint. Whichever one is blue, you respond with your right hand. Whichever one is green, you respond with your left. Right? So if it's congruent, right? If blue's on my right side, blue's on my right side, easy. Same with the left. The moment it switches, you get that non-congruent stimulus and it becomes really challenging. And I like to break this down because, like, again, the cognitive stuff can get so cumbersome and confusing. We're just doing stuff to do it. But there's different levels of attentional control and awareness. And so to me, it helps figure out, like, okay, well, what's my goal, right? Like, okay, if we're going to do tossing a ball with letters and colors and I'm calling things out, okay, well, what's my actual goal? What am I trying to use? So these models of levels of attention, there's focused, which is literally just doing the task, right? So dribble the basketball. There's sustained, which is you do it for a long time. And I think this one is so crucial and easy to do that we miss, right? Like we'll just do a drill for 30 seconds. Okay, well, games are like 2 hours long. I'm obviously not going to do a drill for 2 hours, but try doing that Simon task for 2 minutes. After 45 seconds, it's really hard to stay focused. So for an assessment post concussion, I will actually have athletes do that Simon task. Um, where I can measure reaction time with the device I have. And I do it for 2 minutes and I see how long they can last. Um, so simple, so simple. And then there's different levels where you're switching between tasks, right? Alternating, divided, select, right? Like doing things in a noisy environment versus not. Um, just making sure you have a clear goal of what you're doing. And then, so that's like the cognitive side. And then you have the motor side, right? Watch them do the movement. We are movement specialists, right? Like we know what good movement looks like, right? You know when you see it, it becomes a little subjective, and I get that, right? Like what is good movement? We could go down a whole nother rabbit hole and, you know, Reddit thread on that, right? But, I'm looking for those things. If you've worked with your athletes, like you know what's good. And then I just ask them, I'm like, how does this feel? And they're like, yeah, I feel super slow and it doesn't feel right. Great. Unfortunately, concussion, subjective is a lot of our objective in reality, which is tough, but that's what makes it, I think, really interesting to work with these types of injuries and with these athletes. But that's kind of how I break it down to address those things. And again, I'm doing that with ACL. Whatever you're doing for your ACL patients, just do the same thing. And I think the last point I always like to make with this is, especially with the neurocognitive skill stuff, and you're trying to replicate it in a clinic, right? Like they just need to do the thing. They need to do the sport. That is the best neurocognitive test. Obviously, you can get confined, and I want to make sure that they're safe, and I'm going to do it in this little more controlled environment. But the moment I can get them out there with a performance coach, a skills coach out on the field, on the court with the better it's going to be. Because I can never replicate that neurocognitive load in a clinic type setting. Just have them do the thing once it's safe.
Yeah, I love that. I think subjective is so underrated in sports rehab. I think just like you said, asking them how they feel. Again, you're seeing them, does it match how they feel? And then go from there. If you need to modify it, range of motion, stance, whatever it may be, like just listening to the patient, they'll 95%, obviously no research behind that, but they'll tell you what they're feeling and what they need to improve on after the subjective. And I think you also touched on another great point that I want to kind of wrap up with is like in-season concussion management. Obviously, the interprofessional team is crucial here. Again, I don't know if you want to result back to UFC or if you want to talk about any other experience, but just like how do you manage concussions when they're in season, when you're allowing them to maybe do a sport that is a little bit less impact, and just kind of how that changes sport by sport. I know we can get deep into that, but just general, how are you approaching this?
Yeah, it's always a tough question because it very much depends on where you're at, who you're working with, right? Like there are big entities that have protocols, have requirements that you ultimately have to follow, where there's not a whole lot of choice, but you can at least fill in the gaps on the side with things. But really, ultimately you just got to know the rules, right? Depending on where I might not be making the final decision on if they're clear to play. That might need to be a physician, and having a physician that knows what's going on is probably a little bit more progressive with their understanding of treating concussion is going to be huge. So it's not just educating athletes to come in and care about concussion, it's educating and getting the entire team on board with what's the plan and how much we can actually push them. And I think, kind of like I said before, like utilizing those skills and performance coaches a lot because they know what the right movement looks like. They've probably seen that athlete work and play a lot more than you have, so they know what is probably good and what isn't, or if something has changed. Um, but I think in season it is the same because I'm trying to push people back as soon as possible, especially if they fit into that anxiety and mood domain. They need it the faster you push them, the more confident they get and the quicker they get out of it anyway. Um, but again, depending on who you're working with, I think it's maintaining like a good safe 10, 14-day timeline of the risk of not getting another concussion is huge for me. That is what I push. But in a professional setting, even collegiate nowadays, you don't have the time. And so that's a really long conversation that you got to have with the team to decide that we're all agreeing that this is an okay, safe decision and we're all aware of the risks, especially if you pass on my tests, right? Um, but yeah, it's a tough one. It's a tough question. But in season, I actually treat it very similar to out of season because I'm pushing people quite fast. Way more. That has been the biggest change in my practice is how much more quickly I will push patients and athletes, right? And not just our athletic population, all of our populations. Um, I push a lot harder. I try and get them back out there as soon as possible because that's where they want to be. The people that have symptoms for 2 years, it's because they have changed and adapted the way that they navigate life because of their symptoms and probably weren't getting great care. And when I say great care, it's probably just clinicians or practitioners or other people that didn't really know how to treat it. And that was the care that I got, just like most PTs, right? You go to PT, I've had multiple concussions in the past and bless my mother, she took me to everyone and every place. And I had symptoms for a really, really long time. And so I'm super passionate about trying to get the word out there to push people. And it's not this big, scary thing. It's like super foundational. It can intertwine into the treatment and the care that you're already giving to these athletes and the way that you already practice.
Awesome. Thank you very much. I think we're wrapping it up here. I think that was all the points that I wanted to kind of hit on, and I think you answered all my questions. So is there anything you want to kind of wrap up with regarding this topic, regarding what you want clinicians, athletes, or coaches to know how to navigate these types of situations?
Oh, such a good question. I don't know. I think reaching out to resources, I'm always an open resource. I do have a course coming out with my close colleague Taylor Farley, who is a vestibular PT out of University of Pittsburgh Medical Center. So we do have a course in end of June with at UNLV. But I'm always an open book. I never gatekeep any information. If you're looking for help with anything, I'm always here. That's something I really believe in. But, the way that I try and educate athletes a lot of the times is we treat it just like an orthopedic injury. You hurt your knee, okay, there might be some modifications we initially have to make, right? Like if we can't run, we're probably not running. But I'm going to get you doing everything else that you possibly can in the meantime. We also have like biological tissue healing timelines that we some people think we can change with laser modality whatever, but there's a tissue healing timeline, right? There are other interventions that maybe we can do, right? Like nutrition, sleep. There's all these other modifications in that sense that we can make to help speed recovery. And then I'm help treating your impairments. They're the exact same. And that's, I think, how, as clinicians, we should be approaching this. And that's how I like to educate athletes too. They just can grasp that so much better. Um, it is not this big, ugly, scary thing, but I think it is a huge gap in sports physical therapy that, it is our duty to be, not necessarily experts at it, but be sufficient at it to make a difference and get them early. If we can get them early, the better they do. They showed that recovery timelines are drastically shortened the sooner that they get an evaluation for concussion. So get out there, meet with your high schoolers, right? Get in with physicians. The closer, the shorter we can make that timeline, the better our athletes and our patients are going to do.
Awesome, Olivia. Thank you so much for your time. I know I learned a lot, so I assume all the audience is going to learn. So again, I appreciate your time and thank you very much for hopping on.
Yeah, thanks so much, Don. Really appreciate it. Thanks for having me.